I'll give you a little bit of background on myself. Maybe that'll be a helpful icebreaker. I always like when I'm in a room like this and I've got somebody speaking up front to know that they maybe put their shoes on one foot at a time and tie their laces, and yes, they wear socks, or those sorts of things are important pieces to know that there's a real human being, and that the things that they're talking about has some level of relevance maybe to me. And so with that, I'll draw your attention to a couple of things. I don't have a Zeiss lapel, pin, or name tag. I'm not a Zeiss employee. I have worked with Zeiss, though, however, since about late 2007, early 2008, and have made some very strong commitments in my practice. And I'll share with you a little bit about that in the second half, what my practice looks like. But from a practice standpoint, every piece of Zeiss equipment that I have and every Zeiss product that I'm using, we have paid for in the practice. I want to be really clear on that. I think that's an important piece. We're not a center that just gets stuff gifted to us. We have to make a business case and use case for the things that we're doing. And so Zeiss has been a great partner for us, and we've made some choices in that regard. And that's part of the reason that I'm here this evening, to share what that's looked like and how that's maybe changed or progressed over time. The second piece that I'd like to share with you is, as Dane alluded to, I do have a big family. And I am not, I actually wasn't 3 weeks in Australia. That would have been great, Dane. There was 2 weeks, you were vacation on you, right? That was it. I've been in Australia for about a week, a little bit over a week, which has been great. You guys have a fabulous country, and I will tell you, there is nothing for me, at least, to have it that's more welcoming than to walk into a place that feels familiar after being abroad for quite some time. I've been abroad since October 15th. I actually left on October 15th to visit our son, our oldest son, who is 14 and studying in northeastern China, with a school that my in-laws founded about 20 years ago, roughly, an international school. So he's a freshman in high school, studying there along with his cousin. And so I got a chance to spend a little bit of time with him on way to South India, where I lead a medical mission that I've been leading for about the last 14 years. And on this trip, which was, I think, trip number 10 for the team, we saw, as Dane said, just over 5,000 patients as a clinic. We did about 3,200 evaluations on eye care patients, another 1,200 to 1,300 visits for general medical with 2 ER physicians that were alongside, and another dental team, a dental college that's local to the area. So we're in a village that's about 3 hours away from any major city. So getting into these villages can be a bit of a challenge. Getting out for care is even more of a challenge for these patients, and which is why we've also been going back to the same set or the same geography over the last 14 years to make a more deeper impact and a team alongside them in things that they want to do for their community. So we just finished that up, and I packed up a few things. I'll actually have a little video for you that's very brief, but we actually had a Cirrus 500 with us in country that was hooked up to an old generator, thanks to Joe's team helping to coordinate that and get that into these villages. But the individuals that we serve there, and it's part of the reason that we get a chance, I think, as optometrists to do the things that we do, is the giving back component. But the individual that we serve there takes about 3 days for them to bus out, stay in a city, get cared for, and then bus back. So they can take up to a half week off or longer to get care. And by bringing the care into them, we actually are able to do things like we've negotiated cataract surgeries at $25 an eye. We provide glasses where we're providing the frames, and they're all brand new frames through donors and companies out there that are large manufacturers on the frame side, but we pay for the lenses to be made in country in hopes of teaming with some of the local opticians and opticals to infuse money into the local economy, rather than strictly just coming in and dropping, as a lot of American nonprofits do, and probably nonprofits around the world or NGOs around the world, tend to drop resources into places without trying to leave a lasting impact on community. And most importantly, we team with the group that's on the ground. And that group that's on the ground has been there for the last 30 years and are indigenous and have a vision for their community. So we get to work alongside them and help bring to fruition some of their visions. So got a chance to do that, popped out into Singapore and then into Perth, and I felt like I was in San Diego, which was really, really nice after, showers can be hit or miss. Internet, even though we're out in the village, can be a little shoddy, so it's hard getting in touch with the other 4 of my children and my wife, who at that point in time were now visiting my son in China and have since flown down and met me in Sydney about 3 or 4 days ago now. So There you go, full circle, and you got your orders in. So without further ado, let me dive into a few of these pieces, and we'll talk a little bit about technology tonight. Before we talk about technology tonight, I want to, just a quick show of hands, how many are you familiar? There's 2 studies that were done in Australia. So my hopes in coming here, and excuse me if I drink a bunch of wine while we go, it kind of keeps my throat going. So here, in Australia, one of the things I wanted to do as I came in was understand a little bit more about the country and about the practice of optometry and eye care and what eye care delivery looked like. The last thing I wanted to do was come in and say, well, this is how we do in the States, so guess what? This is what you should be doing and this is what it should look like. But actually to learn what are the challenges, what are the issues, and I stumbled across a few things. Obviously, my study wasn't comprehensive, but there were 2 major studies that have been performed in the last maybe now 10 years, almost 12 years, since these studies were published. And one was on oversupply. Anybody familiar with this study, the optometric supply and demand study for Australia? Some of you are, and have seen this study. And I wanted to just draw your attention to a couple of elements within this. So it's acknowledged that there's between about 4,500 and 5,000 optometrists between Australia and New Zealand, I believe. Or NZ, right? Is that, am I getting that? Somewhere in there. So about 4,500 to 5,000 optometrists with a projected oversupply of about 1,200 ODs. Now, this study, as I read it at least, looked a little small in my view. It seemed to not be very broad in what it looked at. It only looked at things from one real perspective, I felt, or maybe just cursory touched on a couple of other realms, but didn't really dive into the disease demographics. So it acknowledged that there was a growing demand of patients, or there was a growing set of patients. It set forth the demand for eye care services on your Medicare only, not a consumer-based study, which I'm sure there are companies out there that could probably do a much more effective job of taking a look at what motivates consumer demand and why they want to be there. And then tied that to a little bit of aging and disease, but didn't really significantly dive into that. Now, aside from this study, anybody familiar with the study that was published in 2005 by your Department of Health on eye care services and disease? It had a significantly different perspective, not on the supply of ODs or the eye care, how eye care would be delivered, but in particular, I think, around the market opportunity. And so I'll draw your attention to just a few statistics in this particular, with regards to the summary of this particular eye health study, and that was the changing demographic within Australia. So the changing demographic, mind you, this study started in 2002, was based on World Health Organization data, and moved with projections to 2032. And it was on assumptions at that time that were on current immigration policies and everything else. So these numbers could have changed, admittedly, but I want to just highlight a few of these pieces. And likely if they change scaling up, not scaling down, just based on population growth and cities and all sorts of other things, birth rates and such. But what you see in this study that I think is a key component is you're moving from a total population over 55 of 4.4 million to 8.9 million people in that span of time, in that 30-year span of time. So you're going from a ratio of 1 in 5 in the population to 1 in 3. And what do we know happens when we move from under 55 to over 55 with regards to ophthalmic or ocular disease? We see that piece begin to change, right? Now there's a couple of other pieces that were within this. They established their base ratios, and I put a little bit of a contrasting piece on there so you knew how those compared to the last study. But first off, just draw your attention to that little 9.7 million. That's one site problem. That's not a duplicate. That's not saying somebody had a cataract and myopia. That's not somebody saying they had glaucoma and diabetes. It's one site problem only. At that point in time was again in 2002 at 9.7 million based on those demographics. We know that number's increasing or changing over time as well. Just on current epidemiology and if you were just to kind of look at a traditional clinical medicine approach and an epidemiological approach to a study of the market. So that piece is moving forward. But the second piece here is this little ratio. So you've got two OMDs or ophthalmologists to 14 ODs to 100,000 people. And those ratios, when you actually look at the study that was done, the eye care supply study, the previous study that I referenced in terms of talking about oversupply, they used a slightly different ratio, so they were assuming an 18 to 100. Now, if you just take those numbers by themselves, you're talking about 5,000 patient population basis to 1 OD versus maybe closer to roughly 6,000 as a patient basis per OD. So somewhere in that 5,000 to 6,000 range, and that's general population, with an acknowledged component that 50% of the population at this point in time had one sight problem of some sort. So 2,500 patients. Let's get even more conservative than that. Let's say that number was 4,000 to 5,000, 2,000 patients per OD. Now, it doesn't take into account a dense city population versus rural. I acknowledge that. But just looking at it from a purely numbers basis, there's some opportunity that's here. And I want to take that one step further. And that step is just taking the current number of conditions in 2002. So I'm just circling that first column. And this is in AMD, cataract, glaucoma, diabetics, diabetic ret, and then just a total number of all of those. And these are rounded. They're not exact figures. But when you look at these pieces, I put those conditions up specifically because they're conditions that, to my knowledge, Australian optometrists are able to at least participate in the management of on some level, whether it's on a co-management or detection level or the actual ongoing or starting to progress into the management of these conditions. And I think that's really, really important. And I'll draw your attention to one specific one right in the middle here, cataracts. Now, here's something to keep in mind with that growth from 1.5 to 3 million over this window of time. The supply of ophthalmologists in the same window is going unchanged. Not increasing, not decreasing. But just from a surgery standpoint alone, there is a capacity issue with regards to the management from a surgical basis of cataract care amongst your ophthalmology colleagues that are here in Australia. And this is the same demographic shift that we saw starting to occur in the US and that has driven our law changes as it pertains to therapeutics. Now, I oftentimes get the question, well, don't you guys have lasers? In California, we just got the ability to inject in October for the first time. But where you guys are at right now in terms of your law is very similar to where we were at in 2004 when I came out of the Navy in practice and was practicing in a hospital-based setting where I had everything that I could do. The other piece is that lasers in the States are in two regions that I think you would find somewhat familiar to regions that you have in Australia. One is in Oklahoma, which would maybe be comparative to the Northern Territories, a place where not a lot of people live or maybe want to go and live. Oklahoma is that place for us in the US. It's called Tornado Alley. A lot of people do get destroyed by tornadoes there, and they're scared of Californians getting destroyed by earthquakes, which is where I'm at. And the second is that the other is in Kentucky. And Kentucky doesn't have the beauty of Tasmania, but I'm here is a little bit backwards like Tasmanians sometimes maybe are. I'm just telling you what the Australians have told me. I have no idea. So, but the scenery in Kentucky is lousy, and the scenery in Tasmania is amazing. So there the comparisons really fade. It's completely gone. But I bring those pieces up because oftentimes those are what folks will say, hey, wait a second. That really doesn't match. That's not where we're at, or that's not where we're going. Well, I will tell you, at least from when I read these stats right here, there is an opportunity that sits in front of all of us in this room as it pertains to patient care, the treatment and management of diseases and conditions. And it's not about how do I get equipment or how do I equip myself so that I can treat right now necessarily. Some of this is oriented around the detection of the condition and the building towards a clinical practice model that can effectively support what it is that you're jumping into. And some of you, as I've got a chance to meet with or be in practices here, are doing things that are on the cusp, that are driving that edge. And technology is going to be a leader for you. It's going to be a reason why you could or couldn't participate on scale. So without further ado, we'll dive into the technology. But before I do that, let me just throw that out to questions. Are there any questions in the room? Pushback, thoughts, just a different perspective on this?